this is a good article I found. The superficial gliomas radio pathological correlation. I always love this article, which correlates gliomas, or which correlates the radiology with the pathology. So this is from EFIP, which is actually American. I'm not American, even though it is American, the Armed Forces Institute of Pathology, which is in America. So I was technically right. Anyway, so we're going to discuss about these things, and you'll be like, so boring. So there is a ganglioma, desmoplastic infantile ganglioma, DIG, gangliocytoma, and dysplastic cerebral gangliocytoma, pleomorphic xanthostrocytoma, and dysembryonic neuroepithelial tumors. Okay, let's not do things boringly. So here we have a case, a 3-year-old child who is presented with a vomiting and with seizures. So what we have here is basically a right side temporal lobe which is involved predominantly medially, and then when you go up, okay, hippocampus is involved, and then you go, it's basically all the limbic pathway until the hippocampus. After that it doesn't follow the Papez circuit, perhaps. Okay, it isn't. So when you look here, all right, I need to okay, it moves. All right, why this doesn't move? Okay, now it will move. So what we have here is temporal lesion which is hyper intense on T2 and which is iso intense on T1, and not iso intense, actually hyper intense on T1 and iso intense on flare, or maybe slightly hyper intense on flare. And it is showing some patchy enhancement if you see closely in center, maybe because of the necrosis which is going on in the center causing breakdown of blood-brain barrier, and there is no diffusion restriction whatsoever. Interesting. Actually not so interesting for gliomas, because most of the gliomas which are indeed low grade do not show restriction of diffusion, but that is for the discussion for another paper we are working on. Anyway, so what we have here is basically a lesion located in the temporal lobe, predominantly medially, in a 3-year-old who has seizures and vomiting, which is hyperintense on T1, hyperintense on T2, and showing some areas of enhancement. Alright, we got till there. So let us see how much that paper can help us. So here we go. Hyperintense, alright, let me just, hyperintense on T1, hyperintense on T2, variable enhancement, temporal lobe, this thing fits. Alright, even the peak age is 10 to 20 years. Then DIG, does DIG fit? Okay, first year of life. Okay, solid portion is hyper attenuated, so we don't have CT here. So let's move on. But if you see it is hyper attenuating, that means it's cellular, right? And this is hypo attenuating, that means it has more water. That's why it is T2 hyper intense. But if it is hyper attenuating here, that means it does not have that much water, so it will be iso intense on T2. Same with the gangliocytoma, which will be hyper attenuating, which will be highly cellular, and that's why the T2 signal would be hypo to iso intense. So that actually ruled these two out, because these tumors are cellular. That's why they are hyper attenuating. Interesting. Other examples of cellular tumors are, lymphoma or meningioma. So where are the sites of these things? So they are in DIG, they are large heterogeneous cerebral masses, no calcification is seen. Gangliocytoma will be in the floor of the third ventricle, which is the most common location. Glial cells would be absent. Interesting. So then another tumor which will be moving on. So ganglioglioma and DIG both will be cellular, and that's why will be iso to hyperintense on T2, which makes sense. So let's talk about dysplastic cerebellar gangliocytoma, which is seen in young adults. Usually it is hypoattenuating and calcification is uncommon. alternating bands of low and normal signal intensity on T1 weighted images and high and normal signal intensity on T2 weighted images. So there is alternating bands and striated cerebellum, which gives you a very unique look there. So it's a totally different uh, looking lesion, which you won't be confusing with these three. So then pleomorphic xanthostrocytomas, they are seen in adolescent or young adult patient typically, and it has wide age range. You should not confuse this with a pleomorphic astrocytoma, which you see on the posterior fossa, which has a mural nodule, and their differential of that is hemangioblastoma. But that is not what we are talking about here. We are talking about superficial cerebral glial tumors. Yeah, got it. So then the solid portion is hypertenating again, so that means T2 will be iso to hypo, and it is iso indeed. So solid portion will enhance with a meningeal extension. I'm sorry about that. One more lesion we had a meningeal extension was DIG. So in that way, DIG is actually a close differential for pleomorphic xanthostrocytoma. Interesting. Then you have this embryo. So DD. Then you have dysembryoplastic neuroepithelial tumor, which is seen in younger than 20 years. It is hypotenuating, so that becomes a differential of. Oh, okay. So this is also called as a DNET, and it is a bubbly. So it is T1 hypointense and T2 hyperintense. It is located in cortical location in temporal lobe, and neurological deficits are uncommon. So DNET becomes a close differential of ganglioma, which both of them are located in the temporal lobe. Both of them are hypotenuating on CT. And yeah, basically that is it. Both won't cause much of the neurological deficit. So the case which we are having, I would put ganglioma and DNET both as a differential, and DNET I will put lesser down because it doesn't look that bubbly to me, even though it does have a little bubble here. What is it now? Oh, come on, you can see a bubble here. Interesting. All right, so I called. So when I was pausing this video, I was getting a call from the parents of this kid, and they were saying that the child feels fear. Wow, so that goes like a totally different perspective on this. But temporal lobe epilepsies are known to present in an extramotor way, like hallucination. Like people have um, said that gods talk to them, and gods talk to them, or evils, demons, devils, or no matter what, some extra sensory thing which is going on here, something like Sixth Sense movie. That movie sucked. Alright, so anyway, so what I'm trying to tell you is like there are many unknown happening here in temporal lobes, which is supposed to be for just auditory things. Okay, auditory things are really not that much known. Most of the hallucinations are indeed auditory. Are they? I have no idea. I'm just speaking it out. So anyway, we should confirm that. Okay, that will not take more than 1 second actually. Alright, so auditory hallucination. Oh, guess what? You were right. Okay, I guess so. So anyway, thank you so much for listening, and if you have any doubt, please feel free to ask in the comment section, and let me know if you think there should have been any other differential other than ganglioma and DNET in this case, and what other things should be asked in history. And mind you, this is a 3-year-old child, so I don't know how to get out of it from the child and how to ask. Yeah, I have a lot of respect for pediatricians. Oh, me too. Alright, thank you so much. Have a nice day.